friends, welcome to the show Talk with Your Doc. I am Dr. Prashant Jani, and with us is today Dr. Laura Power. She is a gynecologist at Thunder Bay Regional Health Science Centre in Thunder Bay, Ontario. Today we are going to talk about endometrial cancer or uterine cancer. Uterus is one of the very important part of female reproductive system, and it holds the fetus during the pregnancy. And the cancer of endometrium, also called as endometrial cancer or uterine cancer, is fourth most common cause of cancer in women, and it is a sixth common cause of cancer-related death in women. So it is very important to know about the endometrial cancer, what are the risk factors, how to diagnose it, and how to treat the endometrial cancer. And hence, Dr. Laura Power is going to guide us about the same. Thank you, Dr. Power, for coming to the show.
You're welcome. It's nice to be here.
Please tell us about endometrial cancer, how common you see in your practice.
So endometrial cancer is actually, excluding breast cancer, the most common gynecologic cancer in women. It is probably, if you're going to say that there's a best cancer to get, it is probably the best cancer to get because it has a very high cure rate and there is an overall survival of over 95%.
So uterine cancer or endometrial cancer, are there any different varieties of this cancer?
Yes, so you're right. Uterine cancer can be all kinds of different cancers actually. So the uterus is composed of the cervix, the uterine body or the muscle, the lining of the uterus, and the fallopian tubes. But usually when people are talking about uterine cancer, they're talking about endometrial cancer, and that's the lining inside the uterus that gets shed once a month during a menstrual cycle.
So that lining cancer or endometrial cancer has a better prognosis?
It has a very good prognosis, yes.
So what age group patient you see this cancer?
It can happen in younger women, but the most common age group is postmenopausal, so over the age of 55. We start to worry about it in women over the age of 45, but I have seen it in younger women as well.
So after 55, what happens? Like, how do those women present with the endometrial or uterine cancer?
The most common way that a woman will present is with postmenopausal bleeding. So the definition of menopause is no bleeding for 1 year. And then after that, if there's any bleeding, we call that postmenopausal bleeding. And that's usually a strange occurrence for a woman, and that would make them present to their doctor.
So after 55, if the uterine bleeding is there, there is likely that it's something abnormal there.
Yes.
Is there any other cause other than the cancer which can cause bleeding?
Cancer is actually the least common cause of bleeding. Other causes can be vaginal dryness, uterine atrophy, polyps, and polyps are generally benign, and there can be problems with the cervix. Very rarely it's actually cancer, but we always screen for cancer in that case.
So not to get scared immediately.
Exactly, yes.
So what causes this endometrial cancer or uterine cancer?
So uterine cancer, we think, is related to the fact that we have more menstrual cycles in our life than we did, say, 100 years ago. We see a lot more gynecologic cancers than in the past, and this is because in the past, women were often pregnant for most of their reproductive years. So they had maybe 14 periods in their entire life, whereas now a woman may have 12 to 14 periods in a given year. And so with all of that cell turnover inside the uterus, we have increasing rates of cancer of the uterus. We also have increasing rates of the risk factors causing endometrial cancer nowadays as opposed to before.
So pregnancy protects against the cancer?
Yes. So pregnancy is one of the things that actually decreases your lifetime risk of endometrial cancer.
How does that work?
Honestly, I don't know. Pregnancy decreases our risk of cancer in many ways. Pregnancy is kind of a very mysterious thing where the woman's immune system changes so that her body doesn't attack the fetus. And because of that, women are at higher risk of certain autoimmune disorders, but overall they have a lower lifetime risk of certain types of cancers.
That includes the breast cancer probably?
It does, yeah. Breastfeeding and pregnancy are also preventative for breast cancer.
And then Is there any oral contraceptive pill association with endometrial cancer?
No, so the oral contraceptive pill decreases your risk of endometrial cancer because, again, it prevents having lots of cell turnover. It prevents ovulation. The IUD, any type of IUD, so the copper IUD or the hormonal IUDs, also decrease your risk of endometrial cancer.
Okay, and how about the weight? Some obese patients, do they have a risk of endometrial cancer?
Yes, being overweight or obese increases the risk. So our fat cells make estrogen, and estrogen can actually cause endometrial cancer.
So more estrogen exposure, more the risk.
Yes.
So what are the other conditions where you get more estrogen exposure?
So I do have to clarify, it's not just the estrogen. Our bodies make estrogen and progesterone, so you need that balance. When you don't have the balance and you have more estrogen than progesterone, that's when you're at risk for cancer. So that's why the birth control pill is protective, because it has both. But obesity has more estrogen. Women who have poorly controlled diabetes, that can increase the risk. Taking hormones, just estrogen alone, can increase your risk.
Is there any ovarian syndromes also are associated with estrogen production?
Not ovarian syndromes, but there is a Lynch syndrome, it's called. That's associated with colon cancer. And women have an over 50% increased risk of endometrial cancer if they are genetic carriers of Lynch syndrome.
So if the family history of endometrial cancer, then there is a risk of endometrial cancer in the children?
Yes, exactly.
How about any other associated syndromes like P10 or any other mutations or any other syndromes which are associated with endometrial cancer?
So that's a good technical question. The P10 mutation is actually still academic or experimental. So for routine run-of-the-mill endometrial cancer, as far as I know, they're not basing treatment based on that, but it can increase your risk if you do have those mutations.
And then BRCA mutation which are associated with the breast cancer risk, they are also associated with endometrial cancer?
BRCA is associated with breast cancer and ovarian cancer. Potentially BRCA1 may be associated with endometrial cancer, but that has yet to be proven.
Right. And does any smoking or any other risk factor can increase the risk of endometrial cancer?
Lifestyle habits definitely increase the risk. So smoking increases your risk. Exercising decreases your risk. Having a healthy diet full of lots of legumes also decreases your risk. Colon cancer and endometrial cancer kind of go hand in hand. So the same risk factors for colon cancer also affect endometrial cancer.
So healthy lifestyle, having more children.
Yes.
All those things can
Yeah,
prevent.
contraception, being pregnant, exercise, diet, and also maintaining a healthy body weight.
Thank you. We'll take a short break and continue our talk. Please stay for the next part. Thank you. Dear friends, welcome back to the show Talk with Your Doc. Today our guest is Dr. Laura Power and we are talking about endometrial cancer. Dr. Power, you were mentioning about different risk factors for the endometrial cancer. So once somebody has this endometrial cancer, she might have a presentation of like say postmenopausal bleed. What are other signs and symptoms?
So postmenopausal bleeding is actually the biggest symptom, and it occurs very early on in the disease. So before you get endometrial cancer, you get something called endometrial hyperplasia or precancer. So often women will present after not having had a period for years with spotting or bleeding, and that spotting can occur just with exercise, after intercourse, or it can feel like a whole period. And so that is the most common way that women present. It is painless, other than the usual cramping with a period. Younger women present differently. Younger women are used to getting monthly bleeding. Often they present with unscheduled spotting, so spotting in between their periods, or their periods change. So they become heavier or closer together. And it can be difficult to tell the difference between abnormal bleeding at risk for cancer and just regular perimenopausal symptoms.
So younger women will get the endometrial cancer because of the genetic risk factors probably?
Genetic risk factors and also lifestyle factors, increased BMI, poorly controlled diabetes, smoking.
does it present with a mass lesion or lump or bump in the belly or anywhere like that?
No, not at all. So it is sort of spread out over the entire lining of the uterus. There isn't like a tumor or a mass like other types of cancer. So usually it's painless, and also you can't really feel it in your tummy.
And does it stay in the endometrium or does it go to other parts of the body?
For the most part, at first, it stays in the lining, and then it will slowly spread into the muscle of the uterus, and the next place it might go would be the ovaries or the lymph nodes. But that's pretty advanced endometrial cancer.
So once somebody has this postmenopausal bleeding or heavy bleeding or painful bleeding, what should one do?
So you need to present to a primary care doctor. So that can either be your family doctor or walk-in clinic. And then we also have many nurse practitioner-led clinics in our city as well.
And then what happens there? Like, what are the investigations required to diagnose and confirm this cancer?
So the doctor or the nurse will talk to you and ask questions to get a history and decide what your overall risk is and whether the bleeding is at risk for cancer or not. And then if it is, often an ultrasound is ordered, and you will either get an endometrial biopsy done by your family doctor if they are able to do that, or you're referred to a gynecologist for that.
So first step is ultrasound and then followed by the biopsy. So what does ultrasound does? It diagnoses how big is the uterus?
So ultrasound is actually new. When I did my training, ultrasound was considered not appropriate for investigation and only biopsy. But recently, evidence has shown that if we do a transvaginal ultrasound, so that's where they insert a long probe into the vagina and they get really close to the uterus, and we look at the thickness of the lining of the uterus, we can tell what the risk is. It's not a diagnosis, it just tells us a risk.
How long it takes to get the ultrasound done, like one day?
Well, the ultrasound itself takes probably 15 minutes, but it can depend on how busy the ultrasound places are.
And then there comes the biopsy. So tell us about the biopsy, how comfortable it is, how long is the procedure of biopsy?
So if the ultrasound shows that the lining is thick, or your doctor thinks that you're at risk for cancer and need to do a biopsy, then you would go, and it kind of starts off like a pap test. So you go see your doctor. A woman would undress from the waist down, cover up, and then she puts her feet up in stirrups like a pap test. And then we use a speculum to visualize the cervix, or the opening to the uterus. And then we pass a small pipelle. It's very, very thin, about 1 millimeter in diameter, but it's quite long, kind of like a wand. And it goes inside the uterus, and we move it around like a vacuum cleaner, and it sucks out some of those cells. Yes.
And that goes to the pathology.
Yeah, we send it to you, and you look at it under the microscope and tell us.
We tell the different types of endometrial cancers, like there are a variety of cancers with different prognosis.
Yes, the most common would be endometrial cancer. That's the easiest to treat. And I'd say 90% of the women that I see with cancer have that kind of cancer, but there are other kinds.
Right. So once the biopsy comes positive with endometrial cancer, what happens next?
So then it depends on what the biopsy says. So the biopsy will give us a grade 1 to 4, grade 1 being the least amount of abnormal under the microscope. And so if it's grade 1 in Ontario, a general gynecologist like myself would perform a surgery to remove the uterus and the ovaries, usually. And then that goes for further investigation to pathology. If there is higher grade, then we send them to specialized gynecologists who only deal with cancer.
When you say higher grade, what is the difference between different grades? Like, so clinically, like, for patient-wise.
For patients. I thought you were quizzing me.
No.
So grade 1 would be like the beginning of cancer forming, whereas grade 4 is very abnormal looking under the microscope. So as a patient, you would hope for grade 1. It is easier to treat, but ultimately what determines treatment is your stage, which is something different. That's how far the cancer has spread in your tummy.
So the stage, how do you determine the stage by radiological investigation?
So the stage is determined surgically. So that's why we usually also remove the ovaries so that the pathologist can look under the microscope and make sure that the cancer hasn't spread to the ovaries.
So if the cancer has spread to the ovary or to the lymph nodes or to the surrounding organ,
Yes.
that means it has a bad prognosis probably.
It does have a worse prognosis in terms of overall cancers that women experience. It's not the worst. But generally, if it has spread to lymph nodes and outside of the pelvis, then chemotherapy and radiation is required, which is a lot more treatment than just a simple surgery.
Right. So surgery, once patient gets surgery, what is the stay in the hospital like?
So most physicians or most surgeons will operate laparoscopically. In Ontario, a lot of physicians will discharge their patient on the same day. I don't. I keep patients overnight just to watch over them. But typically it can be a day surgery or just a one-night stay.
That's not a high-risk surgery then probably?
Well, all surgery is high risk, but when we perform surgery, we're doing it laparoscopically or vaginally. And so the incisions are very, very tiny.
And then is there any age where you do laparoscopically versus the open?
No, definitely not. So your age, it doesn't matter. You're a candidate for laparoscopic surgery based on your overall health.
And so once the laparoscopic surgery is done, then patient goes home. Does patient come back for the follow-up again?
Yes. So we usually get a pathology report in about 3 to 6 weeks, and then we'll be able to tell if we need to do more treatment.
Okay, we'll take a short break and we'll talk about more treatment in the next part.
Sounds good.
Please stay back for the last part of the section. Thank you. Welcome back to the show, Talk with Your Doc. Today our guest, Dr. Laura Power, is guiding us about endometrial cancer. And we talked about various risk factors, various causes, how the patient presents, various investigations, and then we were talking about the treatment part. And you mentioned about laparoscopic treatment, just like maybe 1 day surgery or maybe 1 day overnight stay probably.
Yes.
Why we go from open surgery to the laparoscopic surgery?
That's a good question. So I think gynecologists actually invented laparoscopic surgery, and it's just a way that we can operate in a way to minimize the big cuts that happen during regular surgery. Not all surgeries can happen laparoscopically, but a lot of gynecologic surgeries can, because the pelvis is a perfect place to operate that way.
So when you remove the organ, you remove it in pieces then?
No, so this is why gynecologists really like laparoscopic surgery, because women have another opening that can deliver the pathologic specimen. Because if a woman has cancer, we don't want to cut the uterus up into pieces in her belly because we could spread cancer there. So you need a large enough incision in order to remove the uterus, which we remove vaginally.
And then what are the cases in which open surgery will be required? Like?
Open surgery is sometimes required in special circumstances. So for women with other types of cancer like ovarian cancer, often it's a big up and down cut, although now they are experimenting with laparoscopic surgery to do that.
Even if advanced cancer also you can operate laparoscopically, or you need the open surgery, like if it has gone to the lymph nodes or surrounding organs?
It's not really how far cancer has spread, but it's the size of the thing that we need to remove. So an example would be in a non-cancer patient, a woman with very large fibroids. If we needed to remove them, sometimes we do need to make a big cut in order to get that out.
So once the patient receives the surgery and staging has been done, what happens next?
So once staging has been done, then we refer to oncology and they decide if adjuvant treatment is needed. So adjuvant treatment is just a fancy word for extra treatment, and that can be chemotherapy or radiation.
So how long is the chemotherapy and what factors determine the chemotherapy?
So the factors, it's actually multifactorial. So the stage or how far the cancer has spread determines that. And also when you look at it under the microscope, you're doing lots of staining and you're looking for different genes and mutations. And so that will direct the oncologist to choose a different type of chemotherapy.
So that goes for how many months?
Depends. It depends.
And does this chemotherapy has a lot of side effects? Or?
So again, it depends on the choice of chemotherapy. a lot of women can be treated with a progesterone-based therapy. Let's say they're not candidates for surgery. So progesterone is one of the hormones that our ovaries makes. It's one of the PMS type hormones. It makes us feel kind of bloated and hungry and moody. Well, we can use high-dose progesterone to treat that, but those would be the side effects. Other chemotherapy agents that are more typically associated with hair loss and stomach upset and weight loss can be used as well.
And is there any role of radiotherapy in the treatment?
So depending on the type of cancer, radiation therapy is definitely used. Sometimes it's brachytherapy, so they put tiny little radioactive beads at the vault or the top of the vagina because that's the spot where the cancer would recur. Other times they use radiation to radiate the whole pelvis.
So once the patient receives all this treatment, what is the prognosis of the patient?
The prognosis is usually really good. So most of the time, I'd say 9 times out of 10 women have stage 1 cancer. So we do a hysterectomy, remove the uterus and the ovaries and the cervix, and that's all that they require.
And then it's curable cancer probably.
It is, yes. And the key is that women will present early because postmenopausal bleeding is so strange that women present very early to their doctor.
Is there any new treatment or new advances in the treatment of endometrial cancer?
Not that I'm aware of in the postmenopausal patient. However, there are women who have endometrial cancer when they're younger, and there are newer treatments that can help to preserve their fertility. So they don't need to have chemotherapy, which would destroy their ovaries, and they don't need to have surgery, which would remove the uterus. And so that could tide them over until they're done childbearing, and then they can have their surgery.
So as a final advice, what would you say to our viewers about how to prevent the endometrial cancer?
My final advice would be to present to your doctor if you have any abnormal bleeding, especially when you're postmenopausal, and also to try to maintain a healthy lifestyle, quit smoking, get out and exercise, and have a healthy diet.
Wonderful. Is there any website or resources would you recommend for people to go?
There's a very good website. If you Google SOGC, so that's the Society of Obstetrics and Gynecologists in Canada, they have a huge array of resources you can click on. So there's one for contraception, one for menopause, one for cancer, one for HPV. It's excellent.
SOGC?
SOGC, yeah. I believe it's sogc.org, but that's why I said Google it, just to be sure.
Thank you, Dr. Power, for coming to the show. Really appreciate your time.
Thank you for having me.
Thank you all being part of the show. Thank you.